So good morning, everyone, and thank you very much for the opportunity to come and speak to you today. I am delighted to be here. I've often been asked to participate in this fantastic conference and always been doing something else. So I'm really pleased to be here today. I've actually been asked to talk to you about nutrition and lifestyle factors in the care of the diabetes patient. I think we're seeing much more diabetes in our clinics these days. And one of the reasons I started to train as a nutritionist was because I was never really sure what dietary advice to give to a diabetes patient. And I was always worried that I would start to give dietary advice and then the patient would say, well, hang on a minute, that's completely different to what my diabetes clinic has told me. So that was one of the things I really wanted to get clear what dietary advice I can give to a patient. So I really kind of want to pass that on to you today. Just to flag up a couple of my professional associations, I don't think they're going to impact on my lecture today, but just so that you know. So I'm a key opinion leader to Dentacare, which many of you know is a dental supplies company. And I work mainly as a brand ambassador to Genji Gel. I'm also an ambassador to the Swiss Dental Academy, which is essentially the training arm of EMS. As Fiona has said, I'm on the education committee of the BSDHT. So I have been a dental hygienist for 40 years. I'm still working clinically 3 days a week. Absolutely loving it. Still learning and still really enjoying treating patients. As you can see from the slide, this is how I used to work on the left pre-COVID. This is how we are kind of working now. But do you know what? At the end of the day, I'm happy just to be treating patients and doing what I love doing. So your course aims and objectives then, which will come out on your certificate. Today, what I really wanted to do was to explore the symptoms and the classification of diabetes, along with the management and treatment of diabetes, and how we as dental professionals can play a part in the overall health and well-being of our patients as a team, a collective team. I wanted to really today provide you with an update and a review of the classification of diabetes mellitus. We're going to have a look at, remind ourselves of the etiology and the pathology of diabetes and what the current treatment modalities are. We're going to discuss the effect of diabetes on oral health, particularly the periodontium and the soft tissues. Then we're going to have a look at nutrition and lifestyle choices for the diabetes patient, and then look at our role in the multidisciplinary care of the diabetes patient. And what I really want you to take away from this presentation when we've done is I want you to be able to understand, define, and clearly understand the different types of diabetes, to be able to recognize the effect this condition has on the oral health of the patient, to be able to feel confident to provide a comprehensive approach to the support of the diabetes patient, and also to be able to compare available treatment options in providing bespoke oral health advice. So we're going to look at the way in which our diabetes patients can possibly be treated and what types of medications they'll be on. So let's just have a look at some of the statistics then. Diabetes affects about 6% of the British population, so 9% of the population worldwide. 1 in 5 UK citizens could have diabetes without knowing it. So that's a lot, and these statistics are going to be reflected in our patients as well. Diabetes UK says that the average sufferer has had diabetes for about 9 to 12 years before they finally get a diagnosis. So that is a long time to have an undiagnosed condition or disease. We know that diabetes is closely associated with overweight and obesity. And the total of the population in the UK that are either overweight or obese is about 61%. And again, those figures are going to be represented in our patients too. The vast majority of patients who have diabetes are going to be type 2, about 90%. And of course, we recognise that type 2 diabetes is one of the most common conditions affecting older people in the UK today. And as I say, that's going to be reflected in our patients too. When it comes to the oral health of the diabetes patient, then often the diabetes patient will have increased inflammation compared to patients who are healthy in the soft tissues. We know that they're more prone to periodontal disease. In fact, periodontal disease is considered to be the 6th complication of diabetes. And in fact, our diabetes patients are 3 times more likely to develop periodontal disease. And of course, if we add smoking into the picture, it's going to be a high risk factor as well, as smoking is a high risk factor for most diseases as well. So the classification of diabetes, we've all just done our periodontal classification, haven't we? So we all love a bit of classification. And diabetes also has been reclassified, although the last one was 1997, so they're probably due maybe for a tweak or something coming up. But we're back to the previous classification was 79. So those of us who've been in dentistry a long time will remember the previous classifications. But we're back to type 1, type 2, gestational and other types. So there are 4 main diabetes classifications. So type 1 diabetes, we used to call it insulin-dependent diabetes mellitus or childhood onset. It's gone back to type 1, and we'll see why in a few minutes. And ultimately, this is due to beta cell destruction and a lack of insulin. Type 2 diabetes, we used to call non-insulin dependent or adult onset, but we've gone back to type 2, calling it type 2. Then there's gestational diabetes. This is essentially women who develop diabetes during pregnancy. And then there are other reasons why diabetes develops. So pancreatic diseases, such as pancreatitis. Cystic fibrosis is also associated as a risk factor for diabetes, as is hemochromatosis. There are also hormone diseases as well, endocrinopathies such as acromegaly, Cushing's syndrome, and hypothyroidism. And then, of course, many of our patients can be on multiple drug treatments as well, and drug inducement can also be part of the picture, such as thyroid hormone, glucocorticoids, thiazides and phenytoin. And then there are genetic syndromes such as Down syndromes, Turner's syndrome, and porphyria. So there are a number of reasons why a patient can develop diabetes, but we know that the most common one is type 2. Slide up there with me. The next slide, sorry, bear with me. Okay, so type 1 then, as we've said, essentially it is an autoimmune disease. It is the autoimmune destruction of beta cells. The beta cells in the pancreas produce the insulin. It produces absolute insulin deficiency. So there's no insulin being produced at all, and it can come on quite acutely. Onset is between days and weeks, so it's very quick onset. 95% of those cases of type 1 are usually diagnosed before the age of 25. And interestingly, there's often a family history of endocrine diseases, hormone diseases, and celiac disease. And that's quite interesting as well, because we're seeing more and more patients that are developing gut disorders and sensitivities and food allergies. And celiac disease is part of that picture. So you'll often see that either the patient or the patient's family have other autoimmune diseases occur. So things like Hashimoto's. Hashimoto's being an autoimmune disease that affects the thyroid gland. And again, those of you that work regularly in practice, I don't know if you're noticing, but certainly I'm noticing we're seeing more Hashimoto's being diagnosed in young men. It seems to be cropping up a little bit more. Addison's is another one, vitiligo, lupus, and pernicious anemia. So all of these things can make a risk factor for type 1 diabetes a little bit more of a factor. Type 2 then, on the other hand, is to do with insulin resistance and a defect of insulin secretion. So insulin is being made there may be less of it, or if it is being made, it's not working terribly well. So we know that it's associated with obesity and lack of disease. There's usually, again, a family history. It comes on often in older age. We know there's a higher prevalence of type 2 in men in the UK than in women. And what generally happens is the beta cells, the cells that make the insulin in the pancreas, because of this constant high level of glucose in the blood, they become exhausted. That triggering of the insulin to mop up that excess glucose, it wears out, it becomes exhausted. So the insulin doesn't work as well, and also they start to produce less insulin. So it can have a genetic base, but we know from the research that it's strongly associated with behavioural and lifestyle factors, the most important being nutrition, smoking, and a lack of exercise. So let's take a look at gestational diabetes, which is quite interesting. So this refers to women who develop type 1 diabetes during pregnancy, so an autoimmune reaction. Women with diabetes prior to pregnancy are not included in this group. They're considered to have pre-gestational diabetes, so that's not part of this group. However, women with undiagnosed asymptomatic type 2 diabetes, which then becomes apparent during their pregnancy, are included in this group of patients. Essentially, this insulin deficiency or resistance, depending on whether it's type 1 or type 2, develops towards the last half of the pregnancy. 9 times out of 10, it will resolve, but these patients will have an increased risk of developing type 2 diabetes later in life. So why does pregnancy cause diabetes? It seems to be generally due to the presence of human placental lactogen, that's HPL. This is a hormone which is increased. It's to do with the human placental growth hormone, along with estrogen and progesterone, which are also produced in greater quantities during pregnancy. It's thought that these three together can influence insulin resistance and can cause insulin resistance in some patients. Okay, sorry, my screen sharing is paused for some reason. With me. Okay, can you see my screen okay?
Yes, it's fine, Juliette.
It's just said that it's my screen sharing's paused, but great, as long as you can see. Okay, lovely. So let's have a look at the etiology of diabetes then. So the beta cells are found mainly in the islets of Langerhans, which again are in the pancreas. So 70% of the cells in the pancreas are beta cells, and these cells store and release insulin. So we know that insulin escorts glucose into the cell. So when we eat something that has glucose in it, it's converted into sugar that crosses the gut, and then it needs to go into the bloodstream, and then it needs to be delivered to the cell so that it can be used in the cell for energy. And it's insulin that escorts the glucose across the cell membrane. If we have too much glucose, so the cells really don't need that much, it will be stored in the liver as glycogen.
Juliette, the screen's not moving. We're still on the pregnancy picture.
Oh, sorry. Okay.
Okay.
Let me stop share and let me screen share again.
You just know how wonderful your slides are, that's all.
Sorry, I know.
It's okay.
I don't know why that stopped. So let me just slideshow. Right, can you see that now?
Yeah, that's fine, thank you.
I've got the etiology of diabetes on.
Yeah.
Fantastic, thank you. All right, so 70% of the islets are in the beta cells, and of course they store and release insulin. There are also alpha cells in the pancreas as well, which produce glucagon, and glucagon, it does the opposite. It raises glucose levels. So it converts this stored glycogen into glucose when we need it, And then there are delta cells there as well, which produce a hormone called somatostatin. And again, that regulates the endocrine system. It controls growth hormone and the thyroid hormones. But the majority of cells in the pancreas are the beta cells, which regulate our insulin. So there are many factors that influence the production of insulin and the way in which the beta cells function. The main one, which has a negative effect, is this hyperglycemia or glucotoxicity, constant high levels of glucose in the bloodstream. Autoimmunity, as we've seen, is another thing which again creates inflammation. Inflammation over a long period of time, again, can cause the gradual loss of insulin expression. It can destroy the beta cells. And along with oxidative stress, which underlies chronic inflammation, we get this impairment of insulin secretion and insulin resistance. It doesn't work as well. And those things together collectively will create a deterioration in glycemic control. But if we look at those factors, probably the one that has the most influence is inflammation. Inflammation and underlying oxidative stress, which we're going to take a quick look at today as well. So again, let's have a look at type 1. We've seen it's an autoimmune disease. It attacks the T cells, which are autoimmune cells. They recognize and attack foreign substances. So that what happens, T cell mediated response and starts to attack healthy cells, and they can also attack the beta cells. 70 to 90% of beta cells are lost by the time of clinical presentation. So there is no sort of medication for this. There's no reversing it. It's very abrupt. Because it comes on very quickly, it doesn't allow the body to provide compensation, metabolic compensation. So it's much more serious, it's much more severe. We can also see then the fact that because it is an autoimmune, that's why it can occur in adults in later life. It's not just a childhood disease. So whilst the majority of type 1 is childhood disease, some adults can develop it in later life due to autoimmune reactions and those conditions and diseases that we looked at previously. Type 2 diabetes then is a combination of things. It's number one, a lack of insulin secretion because the beta cells aren't working very well. And then, as we've said, the pancreas makes insulin, but it's not enough. And it's not working terribly well. The body has become insulin resistant. So it develops chronically over time. The beta cells wear out, so they start to become non-functional. And this is, again, because of repeated blood glucose spikes after a meal, postprandial glucose spikes. So this is the blood becomes saturated with too much glucose and the body can't use it. Sadly, we recognize that type 2 is becoming increasingly more common in children as well. We know that we have a childhood obesity crisis as well. And so again, this is why the classification, I think, has changed, because we know that children, sadly, can also develop type 2 diabetes. The treatment modalities then for our diabetes patients, for type 1 diabetes, it is insulin therapy. It's not going to be dietary controlled. There needs to be insulin and they need to be given insulin. But gone are the days now where the diabetes patient used to give themselves a large bolus dose in the morning, and then they would have to eat extremely regularly at very specific intervals to be able to use up that insulin so that they didn't then go have a hypo and go the other way. So insulin is a lot more advanced now. There are lots of different types of insulin, as you can see from the screen. So we have rapid acting insulin, which can work within 5 to 15 minutes of being given. And often this is given with meals, or if somebody's kind of overdone it and they're in acute hyperglycemia. The short acting insulin that has an onset of between 30 to 60. So that's really useful. Again, that might be used before meals. And then there's intermediate and long-acting insulin, again, so this can provide insulin protection overnight, through the night, along with long-acting. And you can see from the graph below that they all have different activities. So our patients, our type 1 patients, may be on a combination of this type of insulin therapy. And this insulin therapy will be really prescribed to them on an individual basis. So it's always quite a good idea to find out what regime that they're on and what type of insulin they're taking. Delivery then is either the syringe, which is more less common now, although there are still some patients that do inject themselves. The pen delivery system is the easiest, and it's the most convenient and probably the most quickly used. So it can be used very quickly in public. So for those patients who perhaps are taking insulin just before a meal, it can be very quickly and easily done, and that's the most common one. However, some of our patients may have the pump system, and this is continuous short-acting insulin. So this is often used for children because they don't, if they're at school, they can't be injected 4 times a day if they're on short-acting insulin. It can also be used for athletes. So if there's athletes that need to have top-up from insulin, keep their energy and the glucose levels up, it can be useful for them. And also some adults have it as well, particularly if they're struggling to take their insulin, or they're having difficulty through the night as well. So again, there are a number of methods in which our patients will be taking insulin. Treatment then for type 2. So if we go to the NICE guidelines, the number 1 treatment for type 2 diabetes is diet and lifestyle changes. And the guidance from NICE is, what are the dietary changes? What are the lifestyle changes we're going to encourage? A healthy diet as per the general population guidance. So that is quite interesting. And again, we're going to look at that in a minute. So we're also going to recommend increased exercise and physical activity. If weight loss is needed, initially a target of about 5 to 10% weight loss is encouraged. The type 2 diabetes patient may also be given individual meal patterns. So we will look at some of the advice that they may be given, and some of the advice we too can give according to what their insulin sensitivity or resistance is like. Generally, an HbA1c target of 6.5 to 7% blood volume is recognised or advised. So that's the target that they will often be set, but sometimes they might be set something different. So again, it's good just to check that and find out what their target is and how are they managing with that. And as always, as with everything, smoking cessation programs are also recommended as well. So once that has been put in place, the next step, if the blood glucose is not being controlled effectively, is, of course, we then start looking at the drugs. And most of you will recognise metformin. It's the number 1 drug choice once dietary control isn't enough, or the patient is finding it difficult or not adhering. So metformin is not insulin. Metformin is essentially a glucose binder. So what it does, it reduces insulin resistance by making the insulin that is being produced work harder. It allows it to work harder. So first of all, metformin will stop glucose release from the liver to bring glucose levels down. It will also inhibit the uptake of glucose from the gut. So from the dietary factors, it will reduce that in the small intestine. Normally, it's taken 2 to 3 times a day, so either with meals or immediately after eating. And so it acts essentially as a glucose binder. It's not insulin-based. There aren't any insulin tablets. So we're still, patients who need insulin are still having to inject that subdermally. So stage 2 therapy then. So when our patients, so the diet and the metformin isn't working, they've still got high glucose levels, they will then be given a combination of 1 or 2 drugs. The first drug is often the gliptins, which is a DP4 inhibitor. And what DPP4 is, it's a hormone that prevents insulin release. So by knocking that out, it means that whatever insulin is being produced, it isn't being impeded in any way. And that's what the gliptins do. The next stage is the sulfonylureas, the most common being gliclazide. I have 3 patients this week, all told me they're now on gliclazide as well. And again, this stimulates production of insulin from the pancreas. So everything doing the best to maximize what they've got. If they're still struggling, then we're going to see triple therapy. So when we look at our patients' medical history before they come in, we can tell whether they're managing or not simply by looking at the number of drugs that they're on and what type of drugs they're on. They may be on one, they may be on a combination of all three. And then finally, if that is still not working, they will be given insulin as well. And again, this will be injected transdermally. So it's a good idea just to check with your patients what medications they're on, as we always do. But this is the indication as to whether they're struggling with their diabetes and their blood glucose control or not. So how does this then fit in with oral health and systemic health? So all of us know that over the last 10 to 15 years, we are recognizing that there are very specific systemic associations with oral health, and the most best researched with the best evidence base are diabetes, that's the number one, and cardiovascular disease. There are a list of others, and the actual association with those is still, and the mechanism of association is still being researched. But diabetes and cardiovascular disease now are very well established and very well recognized. So the association then between periodontal disease and diabetes is recognized that essentially it's mediated by this pro-inflammatory cascade, chronic inflammation, underlying oxidative stress. The European Federation of Periodontology state that the relationship is bidirectional. So we've always known that patients with diabetes are more likely to get periodontal disease. What we didn't really realize until the last 10 years or so is that patients with periodontal disease are at higher risk of getting diabetes. So what the EFP are telling us, it works both ways. People with periodontitis have a higher risk of diabetes, and patients with diabetes are 3 times more likely to develop periodontal disease. Now, this doesn't mean that diabetes causes periodontal disease, because we know that essentially periodontal disease is a bacterial mediated disease. It's initiated by plaque biofilm. But what diabetes does do is it makes the host less resistant. It reduces their resistance and their immunity. It alters the whole host response, both to developing diabetes and also to inflammation. They don't handle inflammation as well. It can become more systemic. The association then between a systemic inflammation and oral health, inflammation in the mouth, we recognize again is essentially mediated by bacterial translocation, bacteremia. So in other words, bacteria from the oral cavity is dislodged during eating, drinking, brushing activity. It enters systemic circulation through the ulcerated epithelial junction. So we've got gingival inflammation. The tissues are more fragile, the tissues are more permeable, and that ulcerated epithelial junction is more permeable, which means bacteria can cross and get into the bloodstream and then become part of the systemic circulation. So it then, once it becomes in part of the systemic circulation, it then triggers the whole pro-inflammatory cascade. So the relationship between periodontal disease and diabetes, as you can see in the blue box, really centers around these chronic high levels of all the pro-inflammatory mediators in the bloodstream. So if we have a look at diabetes first in the red box, chronic hyperglycemia, so chronic levels of glucose in the blood, causes the creation of advanced glycosylation end products. And one of those products is HbA1c. These products then trigger and initiate the immune system to then start producing all the pro-inflammatory mediators, and at the same time creates oxidative stress, both of which then start to drive chronic inflammation. Chronic inflammation can affect insulin resistance, because we've seen chronic inflammation affects the beta cells. It can destroy the beta cells. And so it creates insulin resistance. Insulin resistance drives diabetes. So we can see one vicious cycle there. If we add periodontal disease in, so we know that periodontal disease, again, triggers the innate immunity, that bacterial initiation, inflammation is created in the tissues. It then becomes systemic. We get this pro-inflammatory mediator response, higher levels of those. Periodontal disease also creates oxidative stress systemically, which underlies chronic inflammation. Chronic inflammation drives diabetes. So we can see it is a real vicious cycle. Chronic high levels of pro-inflammatory mediators can damage or destroy the beta cells, create insulin resistance, and reduce insulin production. And this can be made worse by periodontal disease adding to the picture of chronic inflammation. We also know that there are other shared risk factors such as obesity. So adipose tissue, which is the fatty tissue under the skin that sits mainly around the middle, acts like an endocrine organ. It becomes like a hormone itself. It produces leptin. Leptin is able, again, to produce high levels of pro-inflammatory cytokines, particularly those indicated in both diabetes and in periodontal disease. And again, it further triggers the pro-inflammatory cascade. We know that overweight and obesity is positively associated with periodontitis in adults. We know that there is a 35% increased risk of periodontal disease in obese adults. We've seen there's a threefold risk of periodontal disease in diabetes patients. Patients who have severe perio and diabetes then are 3 times more likely to get renal failure. They have a higher risk of death from ischemic heart disease. We also recognise that untreated periodontal disease affects glycemic control. It makes it harder for our diabetes patients to control their blood glucose because of the underlying chronic inflammation. And we also recognise there are a wide range of diseases associated with diabetes and periodontal disease, all of which add to the increased global burden of disease, both globally, both in our practices, and both on the individual level for the patient. So that's the bad news. The good news is, if we treat periodontal disease, effective treatment of periodontal disease can reduce HbA1c by an average of about 0.4%. Now, that doesn't sound very much, but when you consider that each 1% reduction in HbA1c is associated with a 21% reduction of death with diabetes, 37% reduction for myocardial complications. Also, if we treat periodontal disease, we will find that some of our patients will have a reduced need for insulin administration and medications. So this itself helps us see how we as a dental team are really very much part of the multidisciplinary care of the diabetes patient. And it's absolutely no wonder that the EFP in their manifestation has put out a call to all dental professionals to act in the prevention, early diagnosis and effective treatment of periodontal disease to combat the devastating effect on both the oral health of the patient, but also the general health as well, both for our individual patients and for the health of the society as a whole. So this means often when we see our patients who have very aggressive chronic periodontal disease, 9 times out of 10, there will probably be other diseases associated with that. It's likely that these patients may also have other underlying inflammatory diseases. So if we remember, 1/3 of people with diabetes are unaware of their status. It's 1 in 5 in the UK. Diagnosis is being delayed often 5 to 10 years after real onset. In the UK, it's actually 9 to 12 years. And what we also recognise is screen-detected patients show much better long-term outcomes than clinician-detected. So if we proactively screen patients for diabetes and we pick it up earlier, they've got a much better chance of treatment than by the time that they have very significant significant symptoms finally turn up at their GP because the damage has already been done. They may have had it for 5 to 10 years. So if we catch them early, treatment can be instigated early, and they've got a much better long-term outcome. So we need to kind of think about pre-screening. If we're going to put pre-screening in place, it needs to be cost-effective. So a number of studies was done in the Netherlands and across 2011 and 2013. And what they found that was when screening was introduced in a general medical setting, they only had about a 1% increase in diagnosis. It didn't make that much of an impact. But in the general dental setting, just by periodontal indices alone, there was a 73% success rate in early diagnosis. Now, why would that be? And the reason for that is a patient only goes to the doctors when they're ill. They come to see us in practice 4 or 5 times a year. Or if we're seeing our patients, you know, for periodontal treatment, it's 3 times a year. We are seeing them very, very regularly when they consider themselves to be ill or whether they consider themselves to be healthy. So we're in a better position to be able to pick these cases up early. We're looking at the tissues every day, all day, every day. I look at gums and teeth, and we look at those tissues, and sometimes we can just instinctively know that there's something more going on here. So in these studies, when a point of care HbA1c was introduced, so when this it was introduced in the dental setting along with the screening, there was a 92% accurate diagnosis of diabetes. So that's why we recognise that periodontitis may be an early complication of diabetes. And this gives us the opportunity to identify unrecognised diabetes and pre-diabetes in dental patients and refer them at an early stage. We're in a great position. How does a patient know whether they have chronic inflammation? You know, we're the ones that are going to know. It's not going to be their GP. We're the ones that are going to pick it up first when we look at the soft tissues. There's lots of information that you can pick up from the EFP. I would encourage you, if you're really interested in this, just take a screenshot and get onto the EFP website. Lots of materials there, information for us, information for the patients, infographics. So please do take a look at that and download some of that information. Right, how are we doing for time? Okay, so blood glucose balance then. What information are we going to give our patients? What can we safely say to our diabetes patients? The stage before diabetes is reactive hypoglycemia. So this is when we're getting these high peaks of glucose after a meal, followed by a really sort of low, about 4 hours later, a dramatic drop, an acute drop. And it's called reactive hypoglycemia, and it means low blood glucose within 4 hours of eating. So generally at the bottom, we can see if we have glucose, we should get a medium rise, but over time, a couple of hours, that should actually level off again if our insulin is working well and our beta cells are working well. If we're getting this peaking and dropping, then that's the first stage. So blood sugar peaks and troughs throughout the day. It triggers adrenal activity. So when your blood sugar drops, your adrenals are triggered. Over time, it can deplete adrenal function. This can cause insulin resistance. And as we've seen, it will trigger oxidative stress and chronic inflammation. The symptoms then, some of us might actually, I know this was certainly me in my 20s, recognize some of these symptoms: fatigue, poor concentration, irritability, headaches, palpitations, sweating, low resistance to stress, and noise sensitive. And often that kind of comes on about 3 o'clock in the afternoon. You know, you've had a big lunch, you've been very busy in the morning, you've not really eaten much all morning, you then have your lunch because you're desperate, you get this massive glucose peak followed by this dramatic drop round about 3 o'clock, and that's when these symptoms start to come in. So what can we recommend? So we need dietary control. We need to not go more than 3 or 4 hours without having something to eat. Now, that doesn't mean 3 or 4 meals a day. It generally means you can either split that up into 5 meals or 3 meals and 2 to 3 snacks. We want to concentrate on complex carbohydrates, foods that are low in the GI index, but also good quality protein. Now, it's hard for us in dentistry because we don't like our patients snacking, But as a nutritionist, I can see that we do need to balance our blood glucose. So there are snacks that are tooth friendly, that are not going to compromise their oral health. We want a trickle of glucose into the bloodstream during the day, not these big sugar hits. The glycemic food index really helps us grade how much sugar is going to be converted and how rapidly it's going to be converted. So foods in the low GI index will improve blood sugar balance. And we're looking at scores of about 55 and under. This is going to stop that massive glucose peak and, again, ultimately help with chronic inflammation. You can download lots of different tables looking at glycemic index, glucose being 100, and then from there, rapid, very quick absorption, and then from there, it's graded downwards. And there are some interesting things that come up. Sweet potato is actually lower in the glycemic index than boiled or mashed potatoes. And the reason for that is the starch molecule is more resistant. It takes longer. It's not about how sweet it tastes. The difference between glycemic index and glycemic load is that the load actually takes into account the amount of carbohydrate per serving. So the glycemic index really measures how rapidly it's converted, whereas the glycemic load looks at the whole picture. And generally, it's foods under 10 which have a low impact. So we're looking at foods between 10 and 20, moderate, but anything above 20 is going to be high and be converted quite quickly. Glycemic index then, so when we ask our patients to eat more fruit and vegetables, they come back and they say, yeah, I have orange juice every day, I have bananas every day. They're high in the glycemic index. However, if you combine a glucose with a protein will slow the absorption of sugar, so that will help. There's an interesting thing about potatoes and white rice. They actually, the starch resistance increases once you cool these foods. So if you say, for example, cook potatoes, leave them to cool and put them in salad, they're going to be more starch resistant. It slows the absorption. Rice, again, if you cool it quickly, so under cold water, and then make a salad with it, again, it is more resistant. So sometimes cooked and cooled starches become more starch resistant, and if you combine them with protein as well, that slows the resistance of the sugar. So here are some of the snacks that we can recommend to our patients that are tooth friendly, that are not going to compromise their oral health, and it's a good idea. You can take a little screenshot of that as well, and essentially they're all combining a complex carbohydrate with a concentrated sort of protein to slow the absorption of the sugar. So how do refined carbohydrates drive chronic inflammation? So we know in terms of oral health, the gingival tissues, it can be manifested. Some patients will say, I've been having too much sugar, so my gums are a little bit sore. So how does that happen? When we get that blood glucose spike, we know it triggers chronic inflammation, the expression of all those pro-inflammatory mediators. And again, if we have a look at this piece of research, it shows us how glucose elevates oxidative stress. So there is a linear relationship. There's a glucose challenge at the bottom of the screen. And what's being measured is the oxidative stress over time. And you can see how that goes up with the glucose over a period of about 2 hours. We're getting much more oxidative stress. The effect of refined carbohydrates on the oral tissues is manifested. So when our patients tell us their gums are a bit more sore because they're eating more sugar, they're right. And we've known this for a long time. It's just that the studies got buried, really. So there are 6 early studies which really demonstrated how a reduction in refined carbs and sugar over a period of about 4 to 21 days, depending on the research, all of them demonstrated a reduction in gingival inflammation by about a third. The Baumgardner study is also quite an interesting study. This looked particularly at the impact of the Stone Age diet, so no refined grains, on oral health in the absence of oral hygiene. So they weren't brushing their teeth because they were pretending to be in the Stone Age. 10 subjects, 4 weeks, no refined carbs, mainly a hunter-gatherer diet. And what they found was, even though the plaque scores increased, pocket depth, bleeding, and gingival index decreased over time. So again, just by changing the diet, they were able to reduce inflammation in the tissues. It's not just refined carbs though. So when we talk to our patients about sugar, and they say, oh, I don't have a sweet tooth, I don't eat sugar. It's refined carbs as well: white rice, white flour, white sugar. Anything that has been put through a process makes it much more quickly absorbed into the bloodstream, including instant hot cereals like instant oatmeal. So and boxed processed cereals, they elevate blood glucose very rapidly, as you can see from the graph on the right. And again, that drives chronic inflammation and oxidative stress. Antioxidants really come in. We hear a lot about antioxidants relative to inflammation. As we've seen, oxidative stress is part of the disease process. It drives inflammation. Inflammation is implicated in all diseases, chronic diseases, including periodontal disease and diabetes. Antioxidants really protect against oxidative stress. Oxidative stress really becomes worse where there is a lack of antioxidants present. It causes oxidative damage, tissue damage, and drives inflammation. So if we have enough antioxidants in the diet to offset oxidative stress, it then helps to attenuate inflammation. So we know adequate host defense activity then is really dependent on the antioxidant balance. Having enough antioxidant diet, it limits tissue damage, it prevents inflammation, and prevents cytokine damage. In addition to that, we know that omega-3 fatty acids have a lot of attention around them when it comes to inflammation. They're anti-inflammatory. They're implicated in the resolution of inflammation, both in periodontal disease and also in diabetes and other inflammatory diseases as well. So encouraging our patients to get enough omega-3 fatty acids in the diet. So from this illustration, we can see how omega-3 fatty acids, that they are converted down into EPA. So when you buy an omega-3 fatty acid supplement, you turn the pack over and it will give you the EPA and DHA equivalents. They're the bits, they're the anti-inflammatory bits. And this EPA and DHA comes directly from omega-3 fatty acids. The body can't make it. It has to be put in via the diet. And we can see if we increase our levels of EPA and DHA in the diet, both these studies, 3 studies, have been able to show how levels of pro-inflammatory mediators go down with increasing levels of omega-3 fatty acids in the diet. So it does manipulate inflammation in a positive way. Does it work though? So Brett Back put together a more holistic view of nutrition. Instead of putting lots of antioxidants in or just putting lots of omega-3 fatty acids in, what they did was they took a group of obese men. They reduced omega-6 fatty acids, so they can be pro-inflammatory in some types of inflammation. They increased protein, decreased the glycemic load, and increased omega-3 fatty acids. And what they found was they were able to lower the expression of these pro-inflammatory mediators in a period of about 6 weeks. It was a small group of people, so it's an interesting study. But what was even more interesting was that even though the calorie values were similar in both the test group and the control group, the test group also reported a weight reduction. So it wasn't just calorific content that caused weight reduction. It was this change in the diet, this move away from refined carbs and sugar and saturated fats. Does it work on the oral tissues? Well, again, some really interesting studies coming out. Wilbur et al., again, a more holistic approach to nutrition. So they took a group of study group. They reduced the refined fats, increased the omega-3 fatty acids. They increased vitamins A, C, and D through fruits and vegetables, plus a vitamin D supplement. Lots of antioxidants in there, green tea, berries, fibre. There was no change in the oral hygiene habits, so oral hygiene instruction wasn't given. So despite the plant levels being the same, they were able to demonstrate a decrease in gingival inflammation, bleeding on probing, and overall levels of inflammation in the tissues. So again, they were able to show a reduction in inflammatory markers in the tissues up to about 50% compared with the control group, just by controlling the diet, looking and taking out all the refined carbs and processed foods. If you're interested a little bit more in that and want to read around that, there are some really good key papers. So take, again, a screenshot of that. If not, I can send those papers on to you. I can send you the references. It makes really good, interesting reading. So I think I have a couple of minutes left. So what are we going to say to our patients? Government guidelines in terms of the well-balanced, healthy diet. What we're going to ask our patients to do, our diabetes patients, or all our patients actually, we're going to ask them to decrease and avoid sugar and refined carbs, because we want to stop that postprandial glucose peak. We're going to ask them to avoid excess saturated fats and get more omega-3 and omega-6 fatty acids in the diet. We're going to encourage them to increase lean protein sources and take out the refined carbs, increase their fruit and vegetables, their antioxidant intake. And for our diabetes patients, we're going to encourage them to monitor and manage their HbA1c. And that is actually totally in line with the UK government's recommendation on the well-balanced healthy diet. So this type of information is suitable for all our patients, including our type 2 diabetes patients. Our type 1 patients, yes, they need to look after their diet. They need to be sure that, again, this would be perfectly acceptable for them. But our type 1 patients are also having insulin as well. There are a number of conditions that are particularly common in type 2 diabetes who don't control their diabetes very well. So we see more inflammation, as we've seen. We get more periodontitis because the host response is lower. We know that high glucose levels suppress the white cell activities. That's another reason why they're more prone, diabetes patients are more prone to infection. We might see more dry mouth, xerostomia. We know that chronic inflammation can affect the salivary glands, so they produce less saliva. And also they may be multiply medicated as well. Along with this, if there's a high sugar diet, we're going to see more coronal caries. There's the absence of protective factors if there's not enough saliva present. We also see more burning mouth syndrome in some of our diabetes, poorly controlled, and this can be associated with diabetic neuropathy, so it can be part of that picture. Often our diabetes patients, if they're not controlling their blood glucose very well, can be short of the B vitamins and zinc because they're the micronutrients that control glucose. There may be mechanical factors as well. Dentures, restorations, rubbing, the tissues are more friable, they're more prone to aphthous ulceration. Membrane integrity can be compromised. And also there's a lack of protective factors if there's not enough saliva there as well. We may also see more candidiasis in these patients. So we remember that their host immunity is different. We know that the microbiome, the mix of bacteria changes. That's a whole lecture on its own. But with our diabetes patients, there is an altered microbiome. So their diet and immunity can be affected in different ways. Again, patients that don't control the diabetes very well, they're more prone to things like sore tongue. And this is often associated with B vitamins deficiency, burning tongue, all those kind of soft tissue things often are more resolved when they're controlling their blood glucose well. So the guidance then for oral care from the EFP is that people with diabetes, we should make them aware that they have an increased risk of gingivitis and periodontitis. We always collect a careful history, but looking at their medications will again give us an idea as to how they're managing their blood glucose. We need to ask them at each visit, how are you doing with your blood glucose control? You know, when did you last have your blood glucose test? What are your figures? What's your target? How are you doing with that? So that we can help monitor and encourage them. Again, thorough oral examination. So we do our perio evaluation, we do our carers evaluation. If the patient doesn't have periodontitis, we've got some really well controlled diabetes patients, then we just get them on a preventive care regime and we monitor them regularly so that nothing changes. But our patients who have got acute periodontal infections, we know because their immunity is reduced, they're more prone to systemic infection, we need to get that sorted as quickly as possible. For our patients with periodontal disease, we need to put in periodontal therapy. It's quite safe to give them periodontal treatment, but we need to help them improve their glycemic control as well. And treating their periodontal disease will also help their glycemic control. It's suggested that surgical periodontal implant therapy is not indicated in patients who don't have good diabetes control because the results are far more unpredictable. You can't predict what the hard and soft tissues are going to do in that situation. So when it comes to the clinical implications, periodontal breakdown ultimately is mediated by the host response. It is a reaction to bacteria, biofilm therapy. So we know that biofilm therapy is the first step. They control it at home with good brushing, we control it in the clinic. But our approach to treating periodontal disease shouldn't be just topically as an oral disease, but also systemically as a chronic inflammatory condition. Reduction in bacterial burden is the number one, getting rid of the plaque. Number two, regular recall and surveillance. And then if we pick something up, we're in a position to be able to diagnose or spot early diabetes, then we refer that, onward referral. We need to continue to support the patient, both the host, the inflammatory burden, through nutrition. That means ultimately get rid of the refined carbs, get more essential fatty acids in the diet, more fruit and vegetables, antioxidants, and also encourage our diabetes patients and all of our patients really to keep an eye on their blood glucose balance. We're not wanting this peaking and troughing of the blood glucose. So thank you very much, all of you, for your attention. And it's been absolutely lovely having this opportunity to talk to you today.
Thank you, Juliette. We have got just a small number of questions in here, and if they're too big, as always, just shout and we can take them away and send the responses to everybody. I'm just looking here to see the first one was... I shouldn't read them as I'm trying to find the start, should I?
I know, it's hard, isn't it?
As there is evidence that diabetes does affect oral health, would it not be important for patients with diabetes to be able to have a cost-free oral health check, as they already have free eye checks?
That would be very nice to be able to do that, absolutely, to be able to monitor our diabetes patients much more closely. And that would be fantastic if we could do that. Absolutely, I would agree with that, yeah.
The next one is, what is the strangest questions you have been asked while treating patients with diabetes?
Oh, strangest questions, that's a good one, isn't it? Generally, with my diabetes patients, I will ask them about their blood glucose levels. And do you know what? I think our diabetes clinics and our diabetes nurses probably do a very similar job to hygienists as well, and us in the dental profession, because a patient will come up with all sorts of excuses for why they've got plaque on the teeth or gingival inflammation, and they'll come up with all sorts of excuses to why their HbA1c isn't very good as well. So it's really kind of being able to encourage our patients regularly to just remind them that they need to control their blood glucose, because it's going to be better for their oral health, and also it's going to be better for their blood glucose as well. Often if they get the same message from different healthcare practitioners, it does make more of an impact. So if they go and see their optician, who says, "Oh, your diabetes. How are you with your blood glucose? Because your eyes, we're just concerned about your eyes." Or they go and have their feet done, and the chiropodist says, "Do you know what? How's your blood glucose?" Then they go and see their hygienist or their dental team, and they say, "Do you know what? What's your blood glucose like?" They then start to think, "Oh, okay. Well, that I was told that before." So I think it's a collective thing, really, that we all need to have this sort of collective contribution to looking after these types of patients.
Fabulous. What is the link between diabetes and dementia?
I'm not sure that there is a definitive link. We often talk about associations rather than link. So a link would indicate that there is a recognizable and proven biochemical or physiological pathway. So we talk about associations. I would imagine that an association between diabetes and dementia is probably the inflammation. Most systemic oral health associations or associations between diseases are often based in this whole thing that we've discussed today, underlying chronic inflammation, there's elevated levels of pro-inflammatory mediators. And we know that chronic inflammation, the brain is also a physiological and organ as well. It responds to the chemicals that are in our bloodstream, and it can also be damaged by inflammation and oxidative stress. So I would imagine that is probably the association.
Thank you. Should we not be doing HbA1c screening in dental practices?
This is interesting, isn't it? Personally, just from a clinician's point of view, it would be great if we could do that. What's important is once we've got the result is how we give that result to the patient and how that result is then communicated to the patient's primary healthcare giver, such as the GP. But as we saw with some research, that we're often, if we're going pre-screening, is more successful. We pick up more diabetes patients in our dental clinics because we look at the tissues and we can see that there's not a normal reaction there. And when that is associated with an HbA1c, then the screening for diabetes patients is much, much more effective. So yes, it'd be great. I know in the States they do that. They do blood pressure checks and all sorts in their clinics, and it would be great to be able to do that. The important thing is, what do we do with the information once we've got it? How is it communicated to the patient, and to make sure that it does get through to their primary healthcare provider?
Can I just jump in there, Juliette? Because Anna and I did some research about nearly 10 years ago now, looking at a sample of patients in Warwickshire. And what we were doing was including in the medical history their height and weight. And interestingly, 99% of the patients were quite happy to include their height and weight so we could work out the BMI. And we linked that with the frequency of attendance in their medical practice. And there was quite a high percentage, well, certainly at least 15%, who were obese or overweight and hadn't visited their medical practice in the last 4 years. So they were high risk of diabetes. And what to us was that actually what one could do is tweak the software system in the dental practice to actually, again, introduce this red, amber, green system where we could actually say to the patients, well, actually, the computer says you're at high risk of diabetes. It would be highly advisable for you to attend your medical practice to do an HbA1c. So you could get that checked out. And that seemed to be one opportunity where we could link up with medical practices rather than doing the tests in the dental practice.
Yeah, I think that's a fantastic idea. That is a real illustration of multidisciplinary care, isn't it? Joined up care. And yes, that's fantastic. That's a great idea. Yeah.
Well, the other thing we had, I did some work with Jeremy Dale, who's Professor of Primary Medical Care at Warwick University, looking at diabetes clinics. And one thing we wanted to further investigate was improving the knowledge of the medical team in the diabetic clinics about the impact of periodontitis, and the fact that most of them were totally unaware that there was a link. So there was very few patients were being referred back to their dental practice where there was instances of periodontitis.
Absolutely. And of course, now we have very specific evidence now. The evidence base is really good of that link between diabetes and oral health. And it's really important to do that. I think the other thing is vitamin D and inflammation and periodontal disease as well. Often if I have a patient who, again, I look at the tissues and I think, this is more than what I think we're just seeing. I'll often ask them to go and see their GP for a vitamin D test and a blood sugar test. And that is becoming much more acceptable. I have very few GPs who say, no, that's not necessary. So again, this multidisciplinary care is starting to come out a little bit more. Absolutely.
Thank you.
Fabulous, thank you. So there's only two more quick questions here, Juliette. I know you've been on answering your questions and delivering your presentation, and you're probably eager to get settled and move on to whatever you're doing next. Do you find the social inequalities have a greater impact on the treatments offered to patients with diabetes?
Oh, that's an interesting one, isn't it? I think social inequalities, definitely, and I think social inequalities can also affect everything, really. Their food choices, their education that they have around food, their ability to take on and treat and address their oral health and their systemic health, and also their diabetes as well. And that certainly can be part of the picture. And again, this is why we need this joined up care. So that each time a person visits a healthcare practitioner, they're getting a joined up message, and their treatment is more streamlined and joined up. It's absolutely important.
Okay, this is two questions from one person, and then I think that will need to be the end of the questions, and I can send any more on, Juliette. This is, can TCR T-cell therapy for cancer patients help with diabetes? As well as adaptoimmune.com. My answer to that is I don't know. Yeah.
It's not a therapy that I'm familiar with. And so I couldn't really answer that one. But that's a really interesting question. And it'll be interesting to go away and do a bit of research on that. Yeah.
I'll send that one in to you.
Thank you.
The second question from the same person is psychological stress associated with increased oxidant production and oxidative damage?
Yeah, so we know that stress is another factor. It is indicated in both periodontal disease, and it's also indicated in diabetes as well. Years ago, we used to think that patients who were stressed got more periodontal disease because they spent less time brushing or weren't as effective with their biofilm control. But what we recognize now is that stress is also very physiological as well, and that the stress hormones, adrenaline and cortisol, when they are produced in elevated amounts, they too can affect oxidative stress. And as we've seen, oxidative stress drives chronic inflammation. So there are some very interesting research papers showing as an association, a physiological association between stress, inflammation and chronic disease. Absolutely.